My task was to demonstrate what happened in the real practice with everything what Professor Huber just told you, the story. So how would we are able to apply the knowledge we have and the evidence we have? First question should be if we are fully aware about the risk of the stroke in atrial fibrillation. And the answer is yes, but partly yes. It's not ideal between cardiologist and neurologist, but not very clear among other specialties, and still at a lower level for the patient. This explains why in the real life we are not ideal in preventing a stroke. The second problem, if we are able to apply in clinical practice the risk stratification for stroke and hemorrhage in balancing the advantages and disadvantages of antithrombotic therapy, anticoagulant, and antiplatelet therapy. And the answer is again partly yes. The new risk classification, I'm talking about Schatz-Vask and Hasbled, are well known, but only partly applied. If you are looking in several registries, and I have presented several big registries like Garfield or AFNET registry or Belgrade registry or Romanian registry and other smaller registry like several Italian registry, you can see that we have problem in the right identification of the really low risk patients who are the only patients not indicated for anticoagulation. And we can see in these registries that at least a third of these patients are still anticoagulating, exposing unnecessary to the risk of bleeding. On the other hand, to the other extreme of the spectrum, we have patients with demonstrable risk for thromboembolism who are not anticoagulated. And maybe the worst problem is that we have in almost all registries, doesn't matter the country, doesn't matter the type of practice, too much number of patients treated with antiplatelet therapy, especially with aspirin. And as Greg Lipp shown in a very interesting conference, aspirin is practically has no effect in preventing thromboembolism, but has an effect in determining hemorrhage, gastrointestinal hemorrhage. So people should learn that aspirin is not protective for cerebral embolism in atrial fibrillation. The other problem was to communicate some results from the pilot registry of the European Society of Cardiology and European Heart Association. I was one of the authors of this registry, led by Professor Gregory Lipp. And there are good news and bad news. Good news that the proportion of patients anticoagulated is now rising comparing with other registries, but still not ideal, still 20 to 30% of patients, depending on the country, not anticoagulated. Also the good news that doctors keep in mind that the Hasbled score, high Hasbled score demonstrating a high risk for hemorrhage is not a contraindication to anticoagulation, but only a necessity for careful monitoring of the patient. The other issue discussed during this very nice symposium was how the new anticoagulation drugs were implemented in the clinical practice. And unfortunately, despite the fact that the dabigatran was introduced 5 years before, and shortly after rivaroxaban, and more recently apixaban in almost all the markets in Europe, the use of these novel anticoagulants are still at a lower level. And the use is a little bit higher for naive patients, for the first diagnosed patients with atrial fibrillation, but still low for the conversion of patients still on antivitamin K. Someone can argue that keeping a good INR, we have comparable results with novel anticoagulants. this affirmation is not totally true. First of all, there is a superiority of some novel anticoagulants like dabigatran against preventing thromboembolic stroke. Second, maybe more important, the safety of novel anticoagulants is better than warfarin. And maybe more important, the keeping in the good INR, which means time in therapeutical interval above 68%, ideally above 70, is only the paradise as shown in the title of my presentation, and not the real world. It's very difficult to keep this INR, so the patients are unnecessarily exposed to a thromboembolic risk under anticoagulation therapy with warfarin. There are many explanations for this: the reimbursement, the price, but also the low awareness of the qualities of these new drugs, demonstrated and accumulating now good experience in the field. Another issue discussed in the real practice is the necessity of a very good adherence and the policy linked to the patient, because it's not only the good recommendation and evidence, the patient is the main target of this therapy. So we should have excellent adherence for such kind of patients regarding the anticoagulant therapy. Doesn't matter the old anticoagulants or new anticoagulants. We should do more in this field. And lastly, we discussed a little bit the real life regarding the anticoagulants in different special setting like ablation devices, acute coronary syndrome, and we can see that probably because these procedures are mainly done in specialized centers, there is a good anticoagulation of patients with atrial fibrillation. And now, after completion of several small registries and new registries, after termination of the European Heart Rhythm Association pilot registry, we are waiting for the long-term registry, which is ongoing, and Serbia is participating like many other countries. And lastly, we are going to have, and Tatiana Potpara is dealing with this, a special registry on the patient in all regions, the Balkan regions, because you know, and I've shown from several registries, there are differences in perception of the awareness, in perception of the therapy between countries and even between different kind of hospitals. I cannot finish without congratulating the organizer for this excellent conference, for the high level of the scientific presentation and the very vivid discussion between the faculty and the public.